pay a lot of attention to antiseptic on the floor itself, it's probably not very helpful. Use of overshoes. When you go to NICU, you have overshoes you have to wear. That is not helpful. It doesn't make any difference. So it just adds to the cost, and because you have to buy the overshoes. To wear a gown on top, if you walk into the NICU, to wear a gown. That's also not helpful. Excessive unnecessary use. IM, IV injection. So one of the good things we can do is to try to minimize the amount of medications the baby is getting, especially the injections part. Insertion of indwelling devices. So we had every baby who comes to the unit with a little bit of RDS, he gets a catheter put in. So we stopped that. We said, we'll only put a catheter if we think that the baby will be on the vent for 3-4 days, he'll need frequent blood gases, then we'll put a UVC. Otherwise, we'll leave him alone. We'll just do some capillary blood collection, and we'll not have a central line. So minimizing the indwelling catheter is better. Also, baby now he's getting 80 ml per kg feeding. So now, do we put a central line to give him 150, or do we leave him alone? So now we try to say, okay, if we can get to 100 ml oral, then that's okay. We don't need a central line. We don't need an IV to give him more fluid. And then in another day or two, we'll keep increasing it gradually, so we don't have to put a central line. So always think about central lines, about any catheter that you don't really need. Like sometimes the baby is very sick, you put a urinary catheter, you measure urine output. Once he gets better, we remove it. Nasogastric tube, unfortunately, we use it a lot. So, but probably if baby can suck, then we don't need that. Antibiotics both for prophylaxis and treatment. So this is really important part. When you come to put a catheter, do you give antibiotics because you're putting a UVC or no?
Yes.
Okay. So, for example, if we're doing things under sterile condition, you don't need antibiotics for the catheter. You can give the antibiotics if the baby's sick and you think the baby's septic. But just to put the catheter, you don't need antibiotics. And you don't need to give a flush of vancomycin. It doesn't help.
And the other thing is that for minimizing the catheter, for example, even in a very small babies, we don't put any UVC, UV line if the baby is doing fine on CPAP. Believe me, only OG to you. You start feeding with UVC and the IV, you give peripheral TPN, and then start increasing feed. We don't put UVC, UVC. We don't do that much blood work. If the baby is doing fine, once the day CBGs give us more information. If it is very sick, then of course you put UVC, UAC and everything.
So, and with Dr. Hisham and Dr. Junaid, when we talk about actually the physiology of ventilation or the physiology of breathing and ventilation, we can actually, by looking at the parameters, looking at the baby's breathing, you can make very reasonable judgment of whether this baby is getting better and we can leave him alone, no need to do blood testing, or he's stable, so the previous blood test is probably okay, you don't need to get a new one, or he's getting worse, and in that case you need to do more stuff. So it's important also understanding the physiology of breathing, because this is the most common thing we do for babies, is to give them oxygen, put them on CPAP, put them on ventilation. Usually if a baby doesn't need any of that, they're okay. And you can give them a little feed, they will grow a little bit, avoid central lines. So these are some of the things that we can avoid, and this would help. Antibiotics. So antibiotics is 35% of the total healthcare budget in big countries. So this tells you that how much antibiotics is being used is a tremendous amount. And in developed countries, only 11% are spent on antibiotics. So in developing countries or underdeveloped countries, they actually spend more money on antibiotics. Okay, and nobody, generally the doctor is evaluated by how expensive his antibiotics prescription are. So the more expensive, the more fancy, bigger name, the better. but it's at the end it actually causes more problems and it's not good. So this needs like whole new thinking. Like the doctors have, not only the doctors, actually the patients, because probably if a mother goes with her sick baby to a doctor and he has a fever, so what do you do? Antibiotics? No antibiotics? What if you don't give them antibiotics? They're happy with you, or you're a bad doctor? They'll go to another doctor, right? Then you're the bad doctor that they shouldn't go to next time. So this is, I think, and the way it starts يعني في أمريكا الissues بتاعت الانتيبيوتكس هل الدكتور لازم يدي antibiotics ولا لا؟ It starts من big centers, universities.
Yes.
لما patients يروحوا universities, residents doctors in the university, they go by the guideline of the university. So the patients start learning that not necessary that they get antibiotics every time the baby has a fever. Then it expands. Okay. Good things that are not really expensive is if you have to do sterile procedure, this has money because you have to do asepsis and wear gloves. Remove indwelling catheters when no longer needed. At UVC, once baby is getting up, yes?
Yes, that's what I'm saying. Remove as soon as possible.
So we actually, we were not doing well.
Yeah.
Now we put babies, we have a list of the babies in the unit on a sheet of paper, all the babies. Their age, the weight, birth, weight currently. If they have a central line, how many days the central line is. So you see it in front of you. So it'd say, oh, maybe I should remove it. Yes?
Excuse me, what do you mean by central line?
Like percutaneous line. We use a lot of percutaneous line.
How long you leave it?
There is no specific UVC. If you put an umbilical venous catheter, we remove it after 1 week.
You leave it for 1 week.
Umbilical venous catheter.
Very good.
Okay, umbilical arterial catheter, we use it only if the baby is very sick. Once he's stable and not inotropes are weaning, we can remove. Percutaneous line, there is some data that says, obviously the longer it stays, the more likely it will get infected. So some people say about 15 days and they have to remove it and put in a different percutaneous line. But there's really no good recommendation for that. We try to leave it as long as you need it. But once you don't need it, you should remove it. Don't keep it and say, okay, we'll remove it tomorrow. Because maybe we'll need it tomorrow, so we'll wait. So the idea is to remove it quickly.
You leave it for 15 days if it is.
We leave it actually for a month.
If you need.
Correct.
You don't change it.
We don't change it routinely, no. But I know some places do.
There is some studies actually showed that it's safe to leave the UVC more than 1 week. I think that was 2 weeks.
The CDC is said 1 week, but it depends on your setting. So actually, in Michigan, we culture the UVC, and our UVC, the hub, was getting colonized in 5 days. So we made a guideline that after 5 days the UVC comes out because it gets colonized. It's not going to get infected. It will probably get infected 2 days later. But in 5 days there was bacteria in the connections of the UVC. So we decided to remove it after 5 days. So see how it works in your place. Yani you have to balance removing it and have no access to draw blood, or leaving it and having it get infected. So there is, okay, we'll talk about, there is antibiotic impregnated rubber or a hub that when the needle goes through, it will go through antibiotics. They're trying to prevent infection in different ways, but none of it is really proven completely protects against infection. The best thing to do is, if you don't need it, remove it. And try, you don't have to reach your full fluid, 150 or 160 ml per kg oral to remove the catheter. You can remove it earlier.
Excuse me.
Yes.
When you put the catheter, the preterm baby, when you start to put it, the first day or you wait for 2 days?
We'll put the catheter in the first day because that's when they're sick and they need monitoring. So we
No,
put them when they come to the unit. We put them under sterile procedure, and we give the baby ampicillin gentamicin. We don't cover because the babies are not colonized with staph yet. The skin is clean.
You are asking about the UVC UACs, or you are asking about the PIC line? Because UVC UACs, of course, that at the time of the birth. Yeah, at the time of the birth.
At the admission.
But the PIC line, you know, we put actually as soon as possible. We remove actually UVC in 7 days.
And you remove the UVC or you leave it when you have PIC line?
No, we remove it.
So at 7 days,
Around that.
when we're trying to remove the UVC, we'll say, okay, how much feeding is the baby getting?
Exactly.
If it's going to be, if he's just started, then it's going to be time before he reaches full feed. Then we put a PIC line. If he's getting in the middle,
Yes.
then we'll say, okay, put peripheral for 2 days.
Yeah.
And then we'll live with that. Okay. This is sort of obstetricians. In some places, more actually positioning the baby to drain secretions. It's probably better to leave the baby flat rather than to put the head down to drain the secretions. I think Dr. Hani Ali did a study in Egypt where they put the connection for the ET tube. Did they put it at the baby's side or they put it up?
Yeah.
So, and he said in Egypt, it's better to, the baby's sleeping on his back, the ET tube connection to be at the side, at the same level. If you put it up, there is more colonization and more VAP. Okay, so possible, we don't do this specifically, we keep it straight, but we discussed with yesterday, we have inline suction. Okay, not everybody has inline suction, but it seems the inline suction is that you have a connection. If the nurse needs to suction the baby, she doesn't have to connect the baby from the vent, put a catheter in, take it out, then connect the baby back. This is a device that is connected all the time. So they use it without disconnecting, which seems to be better. Okay, and minimize the number of people in the unit, in the NICU, in the operating theater. Hand hygiene. So hand hygiene is very important, and I think في مصر يعني موضوع الهاند هايجين مش واخد حقه. في المستشفيات هنا في walk around يعني في كل حتة هتلاقي صور زي الواحد يغسل ايده، اغسل ايديه، غسلت ايديك النهارده، الخمسة دول العشرة دول هم أكثر ناس بيعملوا infection. It's a
I think we do have the same now. Most of our
Infection control.
okay. So tell us, like, what do you do? Okay. So what difference did they do? What is that? What does your infection control team do now that you didn't do before?
Observation for all teams and education for all teams in the hospital.
Okay.
Training nurses for hand washing, also all employees in medical field.
Very good. الحاجة the second part of this is alcohol hand rub and hand washing facilities. And لو الواحد لازم يروح لآخر الغرفة عشان يغسل إيده ويرجع تاني يشوف البيبي, becomes less likely to be done. فإن إحنا نسهل الموضوع, يعني يبقى سهل إن at the baby's bedside في الألكحول راب ده الميزة بتاعته, يعني هو you can put it at the baby's bedside. فلو في حاجة حصلت واحد يغسل إيده بسرعة ويبص على البيبي, ما يحتاجش يروح في حتة تانية.
You use antiseptic solution or you have
We use the alcohol rub.
alcohol?
Yes, alcohol rub is recommended.
It doesn't like this alcohol because it makes the hand dry. Yes, yes.
It depends, I guess, on the preparation. We use something called Purell.
Purell,
Yeah, it's better to use Purell than to wash your hands with water. It's less drying. And it smells good. It doesn't smell
I have
bad.
something called Sterilium. It's working good.
Sterilium smells bad, but it works. As long as whatever works in your part, in your unit, then use it. Because Sterilium will work. It doesn't smell as good as Purell, but if if it's okay it's okay. هي الفكرة انت بتحاول تعمله pleasant كده وظريف وسهل عشان يتعمل، لان لو عملته معقد في الاغلب مش هيتعمل. هي الفكرة الموضوع الهاند هايجين ده it will cost يعني it has a money cost but it will save a couple of infections. You're saving on the antibiotics, on the central lines, on the stay in the hospital. هو المشكلة دايما الإدارة ما بتبقاش عايزة تصرف حاجة دلوقتي، يعني لو ادينا فلوس عشان نشتري هاند هايجين سولوشنز مين عايز يدفع مقدم؟ عايزين يشوفوا يعني كل ما توفر لهم هو مش عايزين يحطوا في الميزانية من الأول يعني. فده it's always a struggle between immediate gratification versus long-term benefit. فده يعني لو الاستريليوم ده طب الممرضات مبسوطين بالسكن ولا فيها مشكلة؟ طب الحمد لله. أهم حاجة إن فعلا تبقى practical و easy to use لأنها it will save a lot of money on hospital length of stay, on antibiotic use. بعدين غير كمان the other thing about infection is that once a baby gets a late onset infection, they start deteriorating their outcome. Their outcome becomes worse for neurodevelopmental outcome, hospital stay, so chronic lung disease, chances of getting NEC. So all things get worse from then on.
Between what level do you wash your hands? And if you're examining babies, premature babies, you wash your hands until just hands? With hand rub?
Yeah.
Just
hand rub, yes.
Yes.
Okay.
And each push, الاستريليوم like push it كده مظبوط. طيب. هي الحاجة الثانية في الاستريليوم أو الألكول هاند راب اللي هي 6 steps. أو يعني من هنا لأن in between the fingers is usually an area that doesn't get cleaned well. يعني we need to make sure the tips of the fingers to be done. فده دايما الصور والكامبينز وان في ناس observing في حاجه برضه من الحاجات الكويسه مثلا بتعمل ايه champion يعني احسن واحد بيغسل ايديه نديله جايزه.
And there is penalties for
بالظبط penalties work too بس يعني rewards work better. انت يعني اوكي اكتر ممرضه ملتزمه بموضوع الهاند هايجين تحت الجايزه او الدكتور لان اكشولي التمريض في العاده التمريض احسن من الدكاتره. الدكاتره يعني احنا مش معقوله هندي البيبي انفكشن يعني احنا we're doctors so we don't need to wash our hands. What's worst في الهاند hygiene is the surgeon. Yeah, they don't want to put anything on them. They don't want to clean their hands because they're surgeons.
Recently between patients, especially if you're going to put your hand in an isolate, we do also now the forearm, the part that goes really inside the isolate. So we don't only wash hands, we extend the Purell until maybe forearm or something. That's the part that you think it's going to go in the isolate.
So everything that goes inside the isolate will have Purell on it. لأن most of the campaigns, the hand hygiene campaigns, the pictures بتاعتهم hands only. They don't. Nobody does this. Right,
because we thought this is like an adult-oriented, because we have a problem in infection in our unit. We have a lot of gram-negative. So we're starting to add, we've been more.
Right.
All the hand campaigns were done on adults. There is campaign on units, I think in UK, called Bare Below Elbows. So now that's the recommendation coming from that campaign to extend the Purell if you're examining premature babies in isolate to below elbow, to make it below elbow, not just only hands.
We are actually doing the bare below elbow. احنا في اليونت بتاعتنا كل الدكاترة لما يجوا بنخلع القمصان ونلبس سكراب clean scrub من المستشفى هي نص كم. We no watches, no rings, no.
You do this, you wear scrub before you.
Yes. Every single doctor.
Everybody,
except the surgeons. The surgeons. But every single doctor wears scrub. The ladies يعني will wear something with long sleeve underneath their scrub, but they have to wear a scrub.
Yeah.
We have 3 levels, or we have an infection control department. and they are trying to push nurses and doctors, of course, hard to make hand washing. And we have 3 levels of hand washing. The first one is there is a surgical hand washing, and we are not using the NICU. And second level is the healthy, so they call it healthy or sahi. You wash below elbows, and then the routine in between patients, the routine just in hands. So we have 2 levels, the healthy or the sahi below elbow, and then the routine of the hands and the pushing nurses.
Okay, لغاية هنا.
Yes.
الelbow with
Yeah.
what? الكحول ولا soap and water?
We use different things, but we use betadine like shampoo
Okay.
to make foam, then use soap after it.
Okay.
And sometimes we use soap and alcohol or something like sterilium.
Okay.
But mainly we use betadine and soap.
Chlorhexidine we use, the
How
one
much
for
percent?
the wash.
Which percent?
I don't remember.
Okay. Because the 2.5% is helpful. Anything less than 2% is not
Yeah,
helpful.
that's why they're not using for the very premature baby.
No,
No, talk about
this is
the hand
for hand
This is
washing.
for the hand washing, okay.
For premature babies لما تيجي تعمل sterilization للمكان it's less, it's irritant to the skin. A high concentration at 2.5%, very irritating to the skin of premature babies.
That's what we use.
For little ones we use betadine.
Yes.
لما نيجي ننظف حوالين الumbilical.
Simply.
Yeah.
And we cause burn.
But I think يعني الidea once the awareness increases that
Exactly.
hand hygiene is an issue and it should be addressed, it will make a difference.
Yeah.
إن شاء الله. بس الفكرة إن it wasn't existing. يعني أنا رحت units, very nice unit in ICU في مصر وفيها nice ventilator، الفنتليتر ده وانكيوبيترز أغلى من اللي موجودين عندنا في المستشفى، والمكان كله فيه حوض واحد ومش شغال. يعني ما فيش داعي ان احنا نصرف مصاريف ونعمل مجهود في حاجات غالية ومكلفة، والحاجات البسيطة السهلة اللي هي ممكن تفرق كتير. يعني it's okay ان انت you save the baby by ventilating him, but at 2 weeks he gets an infection and dies. So it's actually not an intelligent thing to do. And neonatology generally now we say babies don't die from RDS, they die from infection. And in RDS we have surfactant, we have ventilation, and we can put them on high frequency, we can do fancy stuff. But المشكلة at the end 3 weeks later they die from an infection. Okay, so sterile items, single use disposable needles, ده كله ده standard stuff. Hepatitis B, post-vaccination.
What is this PP?
Personal protective equipment, PPE.
PP, okay.
The chlorhexidine, I'm sorry for the one you said irritant. Do you wash it after you put it or you keep it?
Or chlorhexidine, we get it, there are one if you scrubbing your hand, you get
No,
it
the
from,
one cleaning.
okay, the cleaning, we get it with a brush. It's a spongy with a brush with a sponge.
Right,
It's
but
sterile.
then
So by the time you rub it around the baby's belly, it starts getting red.
okay, just
2%, the
Takes that
2%,
time.
2.5%. فاحنا we lowered it, we use 0.5%. 0.5% does not cause irritation.
for the premature babies we're using actually the aqueous. We don't know alcohol or the low percentage also about 0.5%.
هو ال 0.5%.
The aqueous one, not alcohol.
It's not effective. It doesn't kill all the bacteria from the skin.
But that one even was irritant. I mean, it caused burns. So we.
I think part of it is the brushing. بس حتى احنا when we use the Q-tips, which is much gentler, it still causes irritation. Okay. So the idea is every place should have their own group, infection control group, infection control committee, task force. Figure out what is the problem they have, put high priorities, get minimum resources that gives you the maximum benefit in your own setting. Okay, we can probably skip this. So this is a nice risk management from the National Health Services in the UK, is that when you form a group, let us look at things that are happening in the unit, because each unit will be a little bit different from the other, and this is how you do this. You divide them into high severity, low frequency, low severity, low frequency, intermediate severity, high frequency, high severity, high frequency, and this is where you start your work, because this is your high priority area, and this is your low priority area, so you tackle this at the end. So you start with the high priority, prioritize. You cannot work on everything at the same time. So put it in steps. And simple measures save lives. Okay, so I don't think we'll go into the immune system. I think we can. Any questions about this, or from your experience? Have you done something and you saw that it actually makes a big difference, or makes a difference at least? Yes.
I have a question. What you are doing for your the people who are more difficult in our unit, like for example X-ray technician, like other people physiotherapy. These are people who are coming and they are very difficult to control.
Actually, this in our place it's the easiest, because we have identified a group of nurses who will monitor everybody who comes, whether they're washing their hands or not, and they give us reports.
Oh, okay.
And they focus on physical therapists with technicians, with other people who don't normally work in the NICU. فهم عشان they know that they're being monitored, they're very good.
Do you lock the NICU?
Yes.
Our door is not monitored at all.
No,
Nobody monitors.
no, you have to
Number.
get, no, not number. Somebody has to let you in.
Exactly.
Our doctors, they have their card, they swipe for their ID. But anybody else, they have to let them in. You have to go through security.
We have also let them in, but our washing area is not monitored. And it's behind the desk, the front desk.
So
nobody sees.
Yeah, he means that if you do like this and this.
Yes, we need to monitor.
No, they have to do hand hygiene before they touch the baby,
Yeah.
not when they come into the unit.
No, I mean X-ray technicians.
Yeah, they have to do it before they come to do the
You
X-ray.
let them inside.
Inside.
Okay.
Yeah. So each room will have a sink, and they have to wash and then touch the baby.
Okay. We have talked about the central castor and these things. I think the source of infection comes for me from the preparation of the IV fluid and antibiotic and the medication. Do you have a guideline or protocol for these things? You receive the medication from the pharmacy, or they prepare it in the unit? I try to use what they call it closed line to avoid infection, but I think it's not working.
What do you mean by closed line?
That means we don't have to extract the fluid from the IV bottle every time. We connect it through a three-way valve, and we withdraw like that. Because we are using syringe pump.
Mm-hmm. There are different ways to do this, but I think it's good to know exactly which point causes you the most of the problems. So you think pharmacy?
Very difficult to do.
Okay. So pharmacy will prepare the TPN, and
yes.
some medications are prepared in the pharmacy. So they do it under negative pressure hood.
Yes,
so, and if we suspect something, we haven't really had a problem, but a few years ago we had one, so we drove fluid from the bags they sent, and we sent it for culture to see if it's the problem or not. Now we talked about one baby we found yesterday. They were twins, and they were in two different rooms, and they were growing the same organism. And then we checked the mother's breast milk and the mother and the father, and they all had the same organism. And some of the medications all antibiotics we prepare in the unit. So the nurses have an IV card, IV drug preparation.
Special nurses.
So it's a group, yes, right,
Yeah.
group. And they will prepare the IV antibiotics and we'll give it in a syringe, because we do everything with the pump also. So with the syringe, you put the syringe in the syringe pump.
Yeah.
And we try not to enter the central line frequently.
Yeah.
So if they're giving it with the UVC, actually we have a rule that antibiotics are not given through the UVC. For this you have to have a peripheral line. So the UVC will stay only with the TPN. So it will only be interrupted once a day.
Well, this is the problem with the TB. We work with syringe pump. How many times you have to extract it from the line?
To do what?
Extract the fluid from the line, from the TBN line, I mean.
Our TPN, you connect it once. Why do you need to extract?
I'm using syringe pump, 50 ml.
Who prepare your
Okay.
TPN?
The pharmacy.
Okay, because we get the TPN in a bag and we
Yes.
put it in the machine that will connect it, and it has
Infusion-
a roller
infusion-
pump, infusion pump.
Infusion pump.
Yeah,
not
for the
syringe.
TPN.
With the TBN.
But other antibiotics are syringe pump.
But you use infusion pump for the TBN.
Correct.
And even fluid like
So
that.
you
you mean you take it from the bag in a syringe?
Yes.
In a syringe.
Where, in the unit?
Yes, it happens.
Not under a
Oh,
hood?
dangerous, huh?
Yeah, this is, you just
I mean,
use
how
the
do you-
infusion pump while you are using the syringe pump.
Then you
Depends on what they have.
كل البريكوشن اللي خدتها في
Ruin it.
preparation you ruin it.
will lose.
So, so
One stick in the bag خلاص that's it.
Okay, in some places, but you need to adjust, adapt according to your situation. So what do you do in something like this?